pancreas and spleen. First, we will start with the pyramid. It lies to the posterior to the stomach and it is separated by the lesser sac. When we consider the parts of the pancreas, it is divided into head, neck, body, and tail. The head lies in the concavity of duodenum, and the tail reaches the hilum of the spleen. That is how it is being placed. And another important thing about pancreas is there are ducts of pancreas. There are two ducts. One is the main duct of pancreas, which is called as the duct of Wirsung, and another one is an accessory pancreatic duct called as duct of Santorini. The main duct of pancreas or the duct of Wirsung begins in the tail of the pancreas and runs on the posterior surface of body and head of pancreas. And the accessory pancreatic duct or the duct of Santorini, it begins in the lower part of head and it opens into the duodenum at minor duodenal papillae. And about the blood supply of pancreas, the arterial supply, pancreatic branches of splenic artery, superior pancreaticoduodenal artery, inferior pancreaticoduodenal artery. These are the arteries involved. And the venous drainage is into the portal vein. Nerve supply, the parasympathetic supply is from the vagus and sympathetic innervation is from splenic nerves. About the functions, there are two parts. There is an exocrine part and an endocrine part for the pancreas. The exocrine part secretes pancreatic juice, which helps in the digestion of proteins, carbohydrates, and fats. And the endocrine part constitutes the islets of pancreas, that is, which is distributed in the tail of pancreas, and in that alpha cells and beta cells is there. The beta cells of islets secrete insulin, and alpha cells secrete glucagon. So that is about the anatomy in brief. Now first we will see about the congenital anomalies. And main congenital anomalies associated with the pancreas are annular pancreas, ectopic pancreas, and cystic pancreas. First, we will see what is annular pancreas. So annular pancreas, as you see in the picture, what is happening is that uh, two parts of the congenital pancreatic tissue. Its name is dorsal part and ventral part. So the dorsal and ventral parts of the congenital pancreatic tissue that will encircle the second part of duodenum. That is due to the incomplete rotation of the ventral part of the gland, and as a result of this, a collar of pancreatic tissue surrounds the duodenum. So because of that, when we see the clinical features, there will be a variable degree of duodenal obstruction. There can be complete atresia of the duodenum, and majority of the cases the condition will remain asymptomatic. And for hello
No,
hello
doctor, you can continue.
And the investigations, plain X-ray, means straight X-ray, barium meal X-ray, etc., will help in the diagnosis. And treatment, when we consider duodenojejunectomy is the most effective way of relieving the obstruction, and means especially it is physiologically ideal. That is, we will remove the compression, means the compressed portion will be removed, and an anastomosis will be created between the duodenum and jejunum. That is the procedure. So that will be the effective way of relieving the obstruction. Next condition, which is coming under the congenital anomalies, ectopic pancreas. So ectopic term is not a new thing to you. In this condition of ectopic pancreas, the pancreatic tissue is sometimes found in other organs in the abdomen. So it is called ectopic pancreas or heterotopic pancreas or accessory pancreas. And the ectopic pancreas will be most commonly found in the submucosa of the stomach, the small intestine, or Meckel's diverticulum. It is also detected in the wall of gallbladder, in the hilum of liver, or within the liver also. And this condition usually does not produce any other symptoms. Another important condition in the congenital anomaly is the congenital cyst. That is, congenital cystic condition of the pancreas. It is extremely rare condition, and it commonly occurs in association with other cystic diseases like congenital cystic disease of liver, congenital cystic disease of kidney. Along with these conditions, there can be presence of congenital cyst in the pancreas also. And one more congenital abnormality which is told as fibrocystic disease of pancreas. So, it is a hereditary congenital abnormality of all mucus secreting glands, and particularly it is more predominant in pancreas and bronchioles. What happens is that in this disease, abnormally viscid mucus is being secreted, and that will cause obstruction to the pancreatic ducts. And due to this obstruction, there will be retention of the pancreatic secretions, and this will result in distension of alveoli, and subsequent rupture is happening. That the pancreatic enzymes will escape and pancreatitis will result. And the pancreatitis further lead to fibrosis. So this is the uh, disease process happening in this condition. And along with that, means along with the pancreas, we have told it is a abnormality of all mucus secreting glands. Other structures are also involved. So in other condition, one thing is that meconium. That is, the meconium will become abnormally viscid, and that will cause obstruction to the intestine, most frequently at the distal ileum. And another thing is there will be viscid mucus in the bronchioles that will cause bronchiolar obstruction. So these are the different structures being mainly affected. And what happens is that the condition may manifest itself at any age. It can be either at the birth, it can be during the infancy, it can be in the older children and in adults also. So depending on the age, or depending on at what age it is being manifested, the symptoms also differ. At birth, when the infant is born, what happens is because of the meconium intestinal obstruction, or because of meconium peritonitis, there will be abnormalities present. Along with the means there can be uh, the passage of meconium will not be happening, so that will be the complication at the time of birth. And in infants, when it is in that age, when it is being manifested, there will be respiratory system involvement. So there can be bronchiolitis, and the patient will be complaining of dyspnea. And along with that, if the pancreas is being involved, then there will be steatorrhea, and the stools will be pale in color, it will be greasy, and it will be having a bad odor. Even though the appetite is much, the infant will remain, the infant will be having cachexia. And along with that, distended abdomen also will be noticed. That is in case of infants. In all older children, it is told that steatorrhea will be there, wasting will be there, and along with that, attacks of respiratory infection, cirrhosis of liver, portal hypertension also will be present. And in adults, steatorrhea and long-standing pulmonary infection are the main presentation. And there can be, means the excess of salt is being lost through the sweat. So in that condition, there can be electrolyte imbalance also. So that is in case of adults. And when we consider the special investigations, it is told that it is based on the chemical test of sweat. We have already told there will be excessive loss of salts through the sweat. And when the chemical test of sweat is done, all patients suffering from this disease, there will be a greatly exceeded amount of sodium chloride and potassium in the chemical test of sweat. That is one thing. And another thing is trypsin in the duodenum will be low, or it will be even absent. That is, there will be a deficiency of pancreatic enzymes. So these two are the investigations which can be suggested. And the treatment, it is told, meconium ileus in condition of meconium ileus, we have to go for surgery. And other conditions, it can be treated conservatively. That is steatoria. In case of a steatoria, fat intake have to be drastically reduced. Extra protein have to be given. Then enteric potted capsules of pancreatin can be given so that to supplement the deficiency of pancreatic enzymes in duodenum. Then along with that, vitamin D, vitamin A can be given daily. And if there is respiratory infection, that have to be controlled by antibiotics. So that is about fibrocystic disease of pancreas. So it is a mucus secreting means abnormality of the mucus secreting gland. Due to that abnormally secreted mucus, there will be obstruction. That obstruction will lead to retention, will cause distension, and finally rupture. And through the rupture part, the pancreatic enzymes will be escaping, and finally it will be leading to pancreatitis and fibrosis. And according to the age, the symptoms will be manifested, and treatment mainly it is a conservative management. Next, it is about the pancreatitis. So pancreatitis, we know it is the inflammation of the pancreas. It can be acute, chronic, or relapsing. Means the main classification, if we take Marseille's classification, that is an important classification of pancreatitis. And according to the classification of Marseille's, the pancreatitis is divided into 4 types. That is acute pancreatitis, acute relapsing pancreatitis, chronic relapsing pancreatitis, and chronic pancreatitis. Acute means acute inflammatory changes which are reversible, and chronic means chronic continuous inflammatory changes which are morphologically irreversible. And another classification is also there based on the etiology, but when we consider it is this Marseille's classification is more important, and that etiological classification is called Trapnell's etiological classification. In the notes I have just mentioned about that. Then now it is about the acute pancreatitis. So, acute pancreatitis, it is an acute inflammation of a prior normal gland parenchyma, which is usually reversible. Means an infection or an inflammation which is happening to a prior normal gland parenchyma. That is called acute pancreatitis, and this condition is reversible. An acute relapsing pancreatitis means when such several episodes occur. That is called acute relapsing pancreatitis. And when we consider the etiology, biliary tract disease is the commonest cause of acute pancreatitis. And uh, other etiologies, it is told like gallstones and choledocholithiasis. That is maybe due to the common channel theory or due to a transient obstruction of the pancreatic duct by gallstones, or due to choledocholithiasis, the gallstones and choledocholithiasis can cause pancreatitis. Another factor is told is alcohol. Alcohol, so many reasons are given for why alcohol is being associated with acute pancreatitis, but among that, to reasonable explanation taken is alcohol stimulates pancreatic secretion. And another thing is the alcohol will increase the sphincteric tone at the ampullary region. So the alcohol increases the secretion, and thus it will lead to acute pancreatitis. Another cause told is obstruction, that is duct obstruction will be associated with the stimulation of pancreatic secretion, which will finally lead to pancreatitis. Then metabolic factors, when we see hyperlipidemia, hypercalcemia, hemochromatosis, these conditions are often associated with pancreatitis. Then vascular factors, it is told, like due to vascular obstruction from atherosclerosis and all, the patient will be developing hemorrhagic pancreatitis. Then post-operative pancreatitis, following certain intra-abdominal operations, pancreatitis may occur. And certain other miscellaneous causes are also too, like certain toxins, certain viral diseases, certain drugs, and certain investigative procedures. These are also considered as miscellaneous factors that can cause pancreatitis. The clinical features may be mild, it can be severe or fulminant, mainly depending on the type of pancreas. Means pancreatitis, it is told like there can be penetrating upper abdominal pain. That is sometimes it can be the acute pancreatitis is described as edematous type and hemorrhagic type, or necrotic type is also mentioned. So based on that, the symptoms also vary. It is told that in edematous pancreatitis there will be penetrating upper abdominal pain which follows heavy meal. The pain will be frequently located in the mid epigastrium and it will often radiate to the back or even the flanks. And while the patient is sitting up, the patient's discomfort or the pain will be improved. And when the patient is lying down, the pain will aggravate. Similarly, in hemorrhagic necrotic pancreatitis also there is pain, and that pain will be cramp in nature, and it will be excruciating in degree, and it will be distressing pain. And the pain can be felt in the right or left upper quadrant. That is, uh, when there is severe involvement of the head, then it will be in the right quadrant, and when there is tail of the pancreas which is being more involved, then it will be in the left upper quadrant. That is based on the uh, region which is being involved in the condition. The pain will be localized in that particular quadrant. And in addition to the pain, there will be persistent and repeated vomiting. There will be nausea, retching, etc. also will be present. And on physical examination, low-grade fever will be present, epigastric tenderness along with guarding rigidity. There will be signs of shock, sweating, tachycardia, etc. Abdominal distension, mild jaundice, cyanosis, and discoloration of skin. Discoloration of skin, mainly it is told in the hemorrhagic pancreatitis because of the extravasation of blood, presence of extravasated blood, there will be discoloration. And the discoloration, it is told that discoloration of the skin around the umbilicus, that is called Cullen sign, and when it is in the loins or in the flanks, it is called Gray Turner's sign. So these two signs are important in this context. That is acute pancreatitis, especially in the hemorrhagic pancreatitis, this Cullen sign and Gray Turner sign will be present. Cullen sign means the discoloration of skin will be around the umbilicus, and Gray Turner sign, it will be seen in the loins. The investigations which can be suggested is serum amylase creatinine clearance ratio, serum lipase, serum lactosans, serum trypsin, trypsinogen activation, polypeptide, assay in serum and urine, then liver function test, blood urea, serum creatinine, blood glucose, peritoneal tap fluid, then plain X-ray, chest X-ray, USG abdomen, uh, spiral CT, MRI, MRCP, RCP, all these will these are the investigations that can be suggested. And about the treatment, if we see, it is told that 70 to 90% conservatively it can be managed. Then 10 to 30% surgical treatment can be done when it is indicated. And there are certain complications like acute pseudocyst, abscess, fistula, hemorrhage, etc. And according to the development of complications, we have to manage the complications also. And in the conservative management, mainly it is the pain relief. To control the infection or inflammation, we can go with antibiotics, then anticholinergics, that is to reduce the sphincter pressure. That is due to the increased sphincter pressure, there will be more of secretions, and that can lead to pancreatitis. So for that, anticholinergics can be given. Then nasogastric aspiration, nutritional support, that is according to the symptoms and according to the condition of the patient. Other treatments also can be suggested like rehydration, then respiratory support, resuscitation, endotracheal intubation, electrolyte management, antacids, catheter. So that is depending on the condition of the patient, conservative management can be decided. And surgical treatment, it is told that it is always deferred in acute pancreatitis. Surgery is always deferred in acute pancreatitis, and the treatment of choice is conservative management. And any attempt to operate will carry a mortality rate, and that will more than 50%, it is told. And to analyze this means to understand the severity of the condition, there is a scoring system it is told, it is named as Ranson's scoring system. That is, we have told surgery is always deferred, and if we go for aggressive treatment such as early surgery, that can that can give a poor outlook. So, a multi-factor prognostic scoring system is used to detect the severity of the condition, and that is called Ranson scoring system. And 9 factors are being considered here, and those 9 factors are age, serum transaminase, then white cell count, blood glucose, arterial oxygen saturation, serum calcium, serum albumin, serum lactate dehydrogenase, and serum urea. These are the 9 factors being considered, and the value it means the limit is also told, like age above 55 years, serum transaminase more than 200 units per liter, white cell count more than 15 into 109 per liter, then blood glucose more than 200 mg per 100 ml. So like that, the values are also given. If it is exceeding, then that is considered as means that will detect the severity of the condition. And the range it is told that 0 to 2, if any of the two adverse factors are present, then it is considered as mild disease. 3 or more adverse factors if it is present, then it is predicting the severe disease. So based on that, the scoring is done. That is Ranson scoring system. And next is about the chronic pancreatitis. Uh, it is persistent, progressive, irreversible damage of the pancreas due to chronic inflammation. And the difference, that is difference between chronic pancreatitis and the chronic relapsing pancreatitis. In chronic relapsing pancreatitis, in spite of the progressive destruction of the gland, there may be asymptomatic periods of varying duration. But in chronic pancreatitis, there is no such asymptomatic period, and the abdominal pain is continuous and unrelenting. That is a major difference in the chronic pancreatitis and the chronic relapsing pancreatitis. The etiology, chronic alcoholism is the most frequent cause of this condition, and it is believed that the obstruction at the ampulla of Vater, that is the factor common to biliary tract disease and alcoholism. This alcohol will cause edema and inflammation of the papilla of Vater, and therefore there will be local effects caused, and that will ultimately lead to pancreatitis. Biliary tract disease like cholecystitis, calculus cholecystitis, choledocholithiasis, these conditions are considered as important etiological factors for pancreatitis. Then the common channel theory is another reason for the cause of pancreatitis tool. Then hyperparathyroidism is found to be always often associated with the chronic pancreatitis. Then similarly, hyperlipidemia also is being seen often with chronic pancreatitis. And then if there is duct obstruction at one or more sites, that also can lead to pancreatitis. Then any kind of congenital anomaly, any kind of trauma, uh, autoimmune pancreatitis, all these can lead to chronic pancreatitis. Now it is about the clinical features of the chronic pancreatitis. So clinical features, if we see, there will be a means the age group, it is told that late 30s and or early 40s, that will be the age group of the patients told. And there will be a past history of chronic alcoholism, or there will be repeated attacks of pancreatitis also. The history will reveal that past history of uh, alcoholism and repeated attacks of pancreatitis. And in this condition, pain is the most outstanding symptom. In majority of patients, pain will be the most outstanding symptom, and the site of the pain depends on the site of the disease. That is, if the disease is at the head of the pancreas, the pain is in the epigastric or right subcostal region. When the disease is in the body or tail, the pain is limited to the left subcostal area, or even there will be back pain. That is, pain changes from intermittent to persistent and continuous. And usually the pain is located in the epigastrium and that will radiate to the back also. As told earlier, the pain is aggravated by lying down and it will be relieved by the sitting and stooping forward position. And the pain can radiate to the left shoulder also. Then, other than pain, other features which are present is one thing is nausea, then anorexia, weight loss, then steatorrhea, malabsorption syndrome, diabetes, cirrhosis, jaundice. These are the other features or other conditions associated with this condition other than pain. Next is about the clinical features of chronic relapsing pancreatitis. So, we have already told there is recurrent attacks. So, here recurrent attacks of pain will be present in the epigastrium, that is the main symptom. This pain also will radiate to the back and it is almost characteristically similar to the chronic pancreatitis. And there is a difference is that the pain will usually stay for 2 to 3 days, and after that there is a period of remission. It is not like in the period of remission the patient will be absolutely painless, but still there will be pain. Pain may appear as quickly as once in a week or as infrequent as twice or thrice a year. So that period of remission that will be varying. And other than pain, the features are weakness or fatigue, then vomiting, jaundice. These are the other features presenting in chronic relapsing pancreatitis. Investigations: serum amylase, blood sugar, liver function test, USG abdomen, CT, ERCP, MRCP, endosonography, plain X-ray, pancreatic secretory juice analysis, oral glucose tolerance test. These are the main investigations that can be suggested in this condition. Then it is about the treatment. So treatment, medical treatment, it is like the aims of the medical treatment, it is told like uh, one is to control the abdominal pain. Next is to treat the exocrine insufficiency, and to treat third one is to treat the endocrine insufficiency. So to control the abdominal pain, it is told one thing: if the cause is chronic alcoholism, there should be total abstinence from the alcohol. Then we have told that there will be steatorrhea and also dietary manipulation, like small volumes of frequent low fat meals can be given. That is, a dietary change can be advised. That is another thing to reduce the abdominal pain. Then high dose of exogenous pancreatic enzyme can be administered. Then first non-narcotic analgesics can be given and later narcotic analgesics can be given. Then octreotide also will help in this condition to reduce the pain. That is, the first aim is to control the abdominal pain. For controlling the abdominal pain, these can be suggested. Next is treatment of exocrine insufficiency. That is, there will be insufficiency by the in the functioning of the exocrine part. So for that, exogenous pancreatic enzyme supplementation have to be advised. That is lipase or trypsin, whatever it is, that can be supplemented. And if there is malabsorption, then H2 receptor antagonist also is advised. Then next thing is treatment of endocrine insufficiency. In that, it is told that insulin therapy, vitamin supplementation, these can be helpful. So that is the medical treatment. So medical management is mainly aimed at control abdominal pain, then treatment of exocrine and endocrine insufficiency. Next is about the surgical treatment. So surgical treatment of chronic pancreatitis, it is usually it's divided into three groups. That is, one is ampullary dilatations, next is drainage procedures, and third is excisional procedures. First, in the ampullary dilatations, it is one procedure is sphincteroplasty of ampulla of Vater. That is, it will prevent the bile reflux. That is, due to that common channel between pancreatic duct and distal common bile duct, it is told as a cause. So by doing this sphincteroplasty of the ampulla of Vater, the bile reflux that will be prevented, and thus we can eliminate the pancreatitis. That is one procedure. Then, to prevent any obstruction, to keep the ampulla wide open and thereby preventing the recurrent obstruction, it is told that transduodenal sphincteroplasty can be performed. And if there is any stenosis, the condition is caused due to stenosis of minor pancreatic duct papillae and all, then transduodenal minor sphincteroplasty or papilloplasty is also performed. These are the main procedures that can be considered under the heading of ampullary dilatations. One is sphincteroplasty of ampulla of Vater, then transduodenal sphincteroplasty, and transduodenal minor sphincteroplasty or papilloplasty. Next is the drainage procedures of pancreatic duct. In this group, two operations are usually performed, and that is dual pancreatojejunectomy and Fustos longitudinal pancreatojejunectomy. These are the two drainage procedures of pancreatic duct. Next comes the excisional procedures, and for excisional procedures, three types of excisional procedures can be performed. One is pancreaticoduodenectomy, then next is distal subtotal pancreatectomy, and third is total pancreatectomy. So pancreaticoduodenectomy, that is modified Whipple operation, that is when the parenchymal disease is limited to the head of the gland. If no other portion is involved, then that in that condition we can go for pancreaticoduodenectomy. And when the parenchymal disease is limited to the body and tail, in that condition distal subtotal pancreatectomy can be done. And when the pain is continuing after lesser resection, again if pain is there, in that condition we can go for total pancreatectomy. So these are the treatment for surgical treatment for pancreatitis. That is about pancreatitis acute and chronic. Next is about the cyst of pancreas. Cyst of pancreas, mainly it can be classified into two groups. One is pseudocyst and next one is true cyst. And the pseudocyst, it constitutes about 80% of all the cysts, and true cyst, it is told like it is only 20%. So pseudocyst of the pancreas or pseudopancreatic cyst. It is caused by the encapsulation of fluid or blood in the lesser sac of peritoneum or in the peripancreatic cellular tissue. That is, the fluid or blood is being encapsulated in the lesser sac, means in that lesser sac of peritoneum or in the peripancreatic cellular tissue, the fluid or blood can be encapsulated, and that will give a cystic appearance. That is called pseudocyst. And the etiology, it is told, can be due to a trauma. That is, a severe blow to the epigastrium can cause laceration of the pancreas, and the pancreatic secretion and blood will escape into the lesser sac and the foramen, and there the encapsulation can happen. So as a result of trauma, this pseudocyst can develop. Then another thing is due to attacks. Either it can be a single attack or after repeated attacks of acute pancreatitis, pseudocyst can develop. Then following a few operations also, this pseudocyst will appear. So that is the etiology. And types, it is told that based on the communication, means whether it is communicating to the pancreatic duct or not, based on that it is classified into two: communicating pseudocyst and non-communicating pseudocyst. And based on the onset, it is another classification told is acute and chronic